So let's go to the radius here on the outside. So it's skinny on top and fatter in the bottom, towards the wrist. And then the ulna, which is this bone here that has that weird hook that we talked about, that fits into the olecranon fossa. It's actually going to be called the olecranon process, so I might as well tell you now. And then so on top, this ulna is a bit thicker, and on the bottom, towards the bottom, it gets skinnier. So on the radial side, we need to know a head. That's the round structure. Then there's a neck. That's the skinny part underneath the head. And then the radial tuberosity is an attachment site for actually, for the interested already, is the attachment site for the biceps, the main front muscle. So the biceps anchors into there. It has a couple of functions that we'll talk about when we get to it. So here's the radius. And then distally, as we move towards the wrist, the main place is as the outside part of the radius comes to a tippy point. That's called the styloid process of the radius. We're going to have one on the ulna also. Right over here. So let's start with the ulna there. So that's the styloid process of the ulna. And as we move proximally on the ulna, we got the olecranon process that we need to be aware of over there. And that's pretty much all that I'm going to be worried about in terms of the ulna. What's interesting here, we have a membrane that's in between these two bones, and that's very, very strong. So those bones can almost be looked at as a unit when you look at it functionally. When we have a palm up and palm down movement, these, in the palm down movement, these will flip over and cross. And so that's actually why the anatomical position is the palm up or forward position. Yeah, so that's for that. And then we get into the carpals and into the hand stuff. And so the wrist and the hand stuff. So the carpals make up the wrist. We have two rows of carpals. We have a row right here, a proximal row that connects with the radius and the ulna. And then we have a distal row, and the distal row connects with the next section of bones, the 5 metacarpals. Meta means in between. That's the palm of the hand. And then from there we have the phalanges, or the fingers that arise up from there. This here is actually the thumb. And the thumb has 2 bones, a proximal and a distal bone. And then all the other digits, all the other fingers have 3 bones, a proximal, a middle, and a distal. I'm not going to go into details of these, all of the carpal wrist bones. I just want you to understand at this point that we have a proximal and a distal row. And there you go, there is a wrist. When we have carpal tunnel, clinically speaking, we have a nerve here that goes through that wrist. So when we look at the wrist, maybe to this direction here, there's a little bit of a valley that's got created, and the valley holds the tendons that go from the forearm into the fingers, and the finger curl up. The muscle function is actually in the forearm. And also with those tendons we have a nerve, and that's the median nerve, that yellow thing, that goes through it. And when we use those tendons a lot, and the median nerve gets squeezed, and that irritates it, and that's then carpal tunnel syndrome, so that hurts. But the interesting thing is, we don't need to necessarily squeeze the nerve here. The nerve can also be squeezed in the forearm, because up in the forearm is the muscle, one of the main muscles that make you be able to go palm down, and that's known as the pronator teres. We'll talk about that next. But when that squeezes all the time, because you type on a keyboard, because always palm down, then that might get irritating. That might irritate the nerve too, because it constantly contracts all the time. And so that's, in the old days they would just do the surgery and cut this open when they have the symptoms. Now, you know, they look at it very carefully to make sure if they need to do surgery go in, that they don't do it and it's not the right problem that they want to fix. So, well, you never want to do surgery and it's not the right problem. That's sort of the thing with that whole thing of surgery. It's delicate. Okay, well that concludes the upper extremities, and now we get to the lower extremities. And the lower extremities start with the hip bone. And the hip bone is also known as the pelvis. It's right here. And we have two of them. We have one on each side. And in the middle, it's connected via the sacrum. The sacrum is the tail end of the spine. So we have this picture here. Then we have this picture here from the side. And I kind of like the side picture here to start with, because I have this crest here that's known as the iliac crest on top. And that's where I can put my hand on when I want to stand. Or I could have my baby sit on it too. But the other reason why I want to start here is because, see the coloring here. We have a brownish, a purplish, and a reddish. And this is the coloring of the three different bones that this hip bone is made up of. So in utero, we actually first have them be three different bones. We have the pubic bone here in red. We have the ischium, this one here, or ischium some people call this, in the back where the sit bone is, this bone you're sitting on, or you're supposed to be sitting on. And then we have the big bone that makes that crest, and that's the ilium. And so the iliac crest is one of the terms. And then as we reach to the front, there is a little tip. You can feel it. There's a bend. There's a sharp sort of turn. And that sharp turn is the anterior superior iliac spine. Anterior is front, superior is above, iliac is the ilium. The spine is just a spiny, pokey thing. We also can go down, if that's harder to feel, but there is an anterior, inferior iliac spine here more in the front. And then as we go backwards though on that crest, we reach back, we get to the posterior bump. There's a posterior bump. There's like, you could reach back, you could feel it. There's a bump in the back. And that bump is known as the posterior superior iliac spine, PSIS. And then we can go further down, and that's a little bit harder to feel again, but it's still in there. It's a deeper bump. It feels actually good when you massage it because there's muscle attachments, and they usually are sore. And that's the posterior inferior iliac spine. And then you go, and when you look at the pelvis and you can look at this picture, there's a deep indentation. That's where the sciatic nerve comes out. But we can't really feel that. That's deep. And that's the greater sciatic notch. And then we get to another bump on the bone, more bony stuff. That is a muscle attachment, and that's the ischial spine. And then we get this big ramus on the ischium, and that's the ischial tuberosity. The ischial tuberosity. And that's our sit bone, where we sit on. So we should be sitting on this bone, the sit bone. We often slouch, and when we slouch, we sit more on the sacrum back here. And so that's when I say to my patients, I say, well, sit on your sit bone. You got to sit upright. Don't sit on your ass. And I'm sorry for saying it that way, but that makes it usually it makes a point. So then, now let's go back to the front again, because it's easier. When you go to the front, we have the anterior iliac spine. We can't really feel that stuff. But then we get to the pubic bone. That's the bumpy bone stuff right underneath the fleshy belly in the front. That's the pubic bone right here. The pubic symphysis is the joint. Pubic symphysis. And then from the side we have this hollow place, and that's the acetabulum, and that's where the femur, the thigh bone, will connect into it. The head of the femur will go into it. And then there is a hole in this bone that's created, and that's known as the obturator foramen. There's actually nothing going through that hole. It's actually a membrane that connects muscle, but it still is a hole, which is probably so the pelvis is not too heavy. So then that's the front view of this whole thing, and what we can see here in addition is the pubic symphysis is sort of nicely laid out. And when we go further down, this is a bone where male and female is different, because the women need to be able to give birth, and so their pelvises are wider, because the baby needs to go through the birth canal through here, there in between. you're not going to be happy if you have to squeeze through this one, because that's a male. So when we look at the pelvis, we have this thing called the falls and the true pelvis, and the true pelvic is like the actual area where the baby needs to go through, and that's much wider in the women. And we can we can differentiate the male and the female pelvis by that, but we can also look at this angle here. It's easier to see. If we have a steep angle like this, that's a male pelvis. If we have a obtuse angle more like this, that's a female pelvis. And so in the X-ray department, it's really funny. They turn it upside down. They flip it upside down and they look at this and they say, look, this is a champagne glass and this is a martini glass. So a martini glass appearance is the female pelvis and the champagne glass appearance is the male pelvis. So that's their language. This is an interesting picture because this here is the back of the pelvis, the butt. There's very strong ligaments, as you can see. This white stuff is very strong connections from bone to bone to hold all this together. But then there is muscles and there is a nerve. This big yellow thing is the sciatic nerve, and that comes out in between muscle. And it can be squeezed in between the muscle. It does not have to be coming from the spine where the problem is. It can be the muscle that causes the problem with the symptoms. Okay, so that's the pelvis, and then from there